Welcome, everyone. My name is Haley Buckner, and I'm the Professional Relations Manager for Elevate Oral Care. Thank you for joining us this evening. Before we start, I'd like to cover a few housekeeping items. For those of you who remain online past 75 minutes, your CE certificate will be emailed within hours of the completion of this talk, so be sure to check your spam folder. You are all muted, so there is no need to worry about background noise. And we will have time at the end for questions. You can submit questions on your webinar dashboard as they will be tracked throughout the talk. We have hosted an extensive series of free live CE webinars on many prevention topics. Each of these webinars were recorded and are available with free self-instruction CE at elevateoralcare.com/elevatingcare. Bookmark this page and return often to see what's new in free CE. If you have a topic you would like to see covered, feel free to suggest it by sending an email to info@elevateoralcare.com or by completing the webinar survey that will be sent after the completion of the talk this evening. We enjoy looking through your suggestions and creating webinars based on your requests. Tonight, we are honored to be joined by Dr. Michael Reagan and Dr. Christina Carter, and it's my honor to introduce you to them. Dr. Reagan has been in dentistry for over 30 years and has been in orthodontics for 25 years. He is passionate about using the most state-of-the-art technology to bring the best, smartest, and most appropriate care to you every day. Dr. Michael, or Mike Reagan, is a native of the Dallas area and graduated from St. Thomas Aquinas Grade School and Bishop Lynch High School. He met his high school sweetheart and wife, Cindy, there. He received his bachelor's degree from Baylor University, where he was a baseball letterman for the Bears, where he graduated with honors. He received his postgraduate training in orthodontics from Nova Southeastern University in Fort Lauderdale, Florida, serving as chief resident. Dr. Reagan is a guest lecturer as well as the past alumni president at Nova. He attends local and national summits and conferences and gives training and lectures. He is also an international speaker on multiple subjects in orthodontics, including bite correction, airway, and sports dentistry. In addition to being affiliated with multiple professional organizations, he also has received many accolades over the years, including being named one of D Magazine's top dentists since the 2000s, and his proudest accolade was being honored as the YMCA Father of the Year in 2013. Dr. Reagan and his wife Cindy were married in 1994, and they have two beautiful daughters, Abby and Caroline. He enjoys sports of all kinds, including hunting, fishing, softball, soccer, and running. And he served as the athletic department dentist and booster club president at the Episcopal School of Dallas. Dr. Reagan is a proponent of mouthguards for all ages, sports, and levels of competition. Dr. Reagan, thanks so much for being with us this evening. I also am excited to introduce you guys all to Dr. Christina Carter. She's the owner of Carter Smile LLC in Madison, New Jersey, where she practices pediatric dentistry and orthodontics. She is a graduate of Haverford College in Haverford, Pennsylvania. She earned her dental degree at UMDNJ NJDS, which is now Rutgers School of Dental Medicine. Dr. Carter earned her certificates in both pediatric dentistry and orthodontics at New York University College of Dentistry. She completed a fellowship in cleft, craniofacial, and surgical orthodontics at the Institute of Reconstructive Plastic Surgery at New York University Langone Medical Center. She is a diplomat of the American Board of Pediatric Dentistry and a fellow of the American Academy of Pediatric Dentistry. More recently, she earned her certificate as a holistic health coach from the Institute of Integrative Nutrition in New York. Dr. Carter has been named multiple times as a top doctor by New Jersey Magazine and a favorite kids doc by New Jersey Family Magazine. She has served on the AAO Council of Orthodontic Healthcare and multiple AAO committees. She is a past president of the Northeastern Society of Orthodontics and served as their delegate chair to the House of Delegates. She often appears on Sirius Radio, Dr. Radio, AAPD podcasts, and has been published in Scholastic and Kiwi magazines. In addition, she has appeared on Inside Edition, WPIX News, and Today.com. She lectures nationally and internationally on both pediatric dentistry, orthodontics, and treating patients with special needs. Dr. Carter is an assistant professor at New York University College of Dentistry in departments of pediatric dentistry and orthodontics, and she volunteers with her certified therapy dog, Callie, through Creature Comfort Pet Therapy in New Jersey. Dr. Reagan and Dr. Carter, as you can see, are very accomplished individuals, and we are so honored to have you guys here with us this evening. So, Dr. Carter, I'm going to let you take it away.
Thanks, Haley, for having us tonight. I know that Dr. Reagan and I are excited for a fun webinar. You've already heard our background and our disclosures. And as a pediatric dentist and an orthodontist, I start seeing my patients at a very early age. So I may be seeing them at a year old, and we're starting to identify problems and issues in the mouth of growth and development and how things are forming from the start. And we start talking to parents about it too. And oftentimes in the past, we thought about orthodontics not starting until we had all or almost all of the adult teeth. But things are changing. We're starting earlier, we're creating skeletal harmony, and we're making more room for teeth to fit. The AAO has their guidelines for the reasons for early treatment, and we know that if we see cross bites of the front teeth or posterior cross bites or severe crowding, open bites, extreme overjet, deep bites, underbites as many people call them, or excess spacing or habits, we refer to an orthodontist. But we're going to talk more about this. And even my office manager's son, who used his pacifier for far too long, he would think they would know in my office, ended up in this scenario with some habits. And so we have lots of imaging, and Dr. Reagan will get into this, where we'll see why we're screening our kids early. And we're not just waiting till the age of 7, but every child should be seen by the age of 7. Here we go, Dr. Reagan. This is all about you.
Yeah, thanks. And the great thing for me, and I know in your own office, Dr. Carter, you have yourself as your internal referral, but I work with a pediatric dentist as well. And so this early screening she's talking about is super important so that we keep up with all these different patients. So when we look at the early screening, it's for a lot of different reasons, and you can see them here. And we'll go over some of these more in depth throughout time. But I think my number one is moms want it many times now, which we hadn't heard that in the past. So when we start with the screening, we're going to look at all the different components. The dentition, which the pediatric dentists out there will have that down pat. But then we're looking also at the bite, overjet, arch length, and some other clinical findings. So we start with the screening, and everybody's got a different one. This is one that I developed with my friend, Dr. Mike Plunk, who's dual trained pedo ortho, and it goes through each of these areas to look at. So we'll first start with classification, and angle is the way we're all trained to do this, but to me, I think it's better to define it in a little bit different way. So just as a reminder, when we're talking about primary dentition and how it affects future occlusion. So we start talking about the terminal plane. You have distal step, FTP or flush terminal plane, and mesial step. So let's look at what each of those do. So flush terminal plane, it will develop into class 1 most of the time. You'll have a class 2 tendency in 43% of the time. And then there's 0 class 3 in these types of cases. With your mesial step, you're still going to develop mostly class 1, but it depends on the amount of overjet. Class 2 also comes from here, but this is where the class 3s all come from. And then when you have your distal step, you can probably figure out with a single arrow, it always becomes class 2. So just a quick reminder. So I like looking at this more as molar, canine, anterior, because each of them can sometimes mask a problem. So I break it down like this: right molar, right canine, anterior, left canine, left molar. So each of these will have their own score. So if you look at cases like this that are unilateral, you look at it on the right, it's end-on class 2, and on the left, it's class 1. So you have different ways of looking at it. And many of your class 3s are asymmetric. So in the scoring example, this is the unilateral side. If you score this, you'll see that we have the left molar is end-on class 2 or class 2, left canine is class 2, and you go through the sequence to define each area. Overbite and overjet, and I measure it probably the same way everybody does, but in the screening, simple, easy terms. Now, in scoring these overbite and overjet, I don't like the word mild, and I'm seeing this trained for a long time. I think normal is a better way to go. And we've had this happen when the pediatric dentist I worked with was talking to mom and said it was a mild overbite. And they're like, whoa, 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 we just had ortho phase 1 done. It shouldn't be mild. So I think normal or norm should be better used as the standard when everything is right. Same thing with overjet. And then arch length. I don't think we should say mild for those cases that have none. I think we should actually use the word none. And that way it's a good clinical cue to the parent that nothing is needed at that point. So primary dentition, of course, we have the primate spaces, which the incisors typically are spaced and upright. The primate spaces show most of the time we assume it's going to be a non-crowded case. But how about those cases that have the crowded primary dentition? Well, most of the time it is a crowded case. And then the rest of the time, believe it or not, like 34% of the time, it's not crowded. So now we're looking at our clinical findings more than just those individual things and radiographic findings. So clinically, cross bites, which Dr. Carter talked about earlier. But with the cross bites, we have to think about it. Is it bilateral or unilateral? And with the bilateral, many times they have the functional shift. And that's easily described by the midline deviation in most cases. If you look at both of these, they both have a midline deviated towards the side of the cross bite. That's a true bilateral cross bite. Versus the unilaterals, many times those are single tooth, but in some cases you can have it in individual teeth. Ectopic eruption, the lower right is actually my youngest daughter. And on the upper left, you see the lateral incisor, which is the ones we see many times coming in sideways. Radiographically, this is my daughter I was showing you earlier. This is where she went from T1 to T2, if you look at the lower right canine. So this is where constant screening with just clinical and with your radiographs can help you determine when things are needed. Of course, open bites and frenums. And then looking at the tongue at rest. We're hearing more and more talk about airways, tongue posture. My daughter's in speech pathology training. She is a resident at Vanderbilt studying this. And we're hearing more and more about this tongue posture at rest or myofunctional therapy. Habits and the use of habit appliances. Both of these cases are thumb suckers. So you see that overjet. Sometimes you'll see open bites and cross bites. And then looking at things that will affect us in the future. Small teeth or peg laterals. And of course, many times you have atopic or missing teeth. Sometimes you have things like this, transposed. You see the canine is mesial to the lateral incisor. So we had to do a little treatment to make that end up in the right place. And you can see it radiographically very early in the mixed dentition phase like this. We could have at least started to prepare the patient for the fact that these teeth may come in that way. Ankylosed, like we see here, and that not only affects the eruption of the teeth, but it also affects the bone height, especially in cases where we have missing teeth. Abnormal eruption sequence, if you look on that side, you'll see that the primary, lateral, and central are in. On the other side, we have the permanent lateral and central. So trying to make sure that we stay on top of these things. Supernumerary and especially the mesia dens, many times when you see things like we saw on the previous slide, it's because of something like this, a mesia dens, it's affecting the eruption of the teeth on that side. The congenitally missing, which most of the time, of course, is the lateral incisors, but many times can be the lower second bicuspid. So you see it here where the canine is erupted into that missing lateral incisor space. So in this case, we'll have to determine, do we open the space or do we close the space? And then you have, many times you have a combination of things missing in one place, as you see in the lower anterior, and supernumerary teeth, as you see on the upper right, with 2 lateral incisors. So the important thing with many of these is to start preparing the parents and the patients up front, especially the parents, for the future and what it's going to look like, and how some are going to stay baby teeth, some are going to come in with an extra tooth that we may have to do something about. So the early intervention and early treatment, phase 1 interceptive. I like interceptive as the way to talk about it. To me, that's a better term about what we're doing nowadays. Dr. Carter talked about how we're doing things a little bit earlier than we used to. And so to me, interceptive is what we're really trying to do, intercept the problems. And so when you look at this, we're trying to determine, are there facial factors, are there developmental factors? And then what we don't look at many times is the social and psychosocial components to this. So we look at that early treatment benefits. We talked about that, the moms want it, and many times that's the reason. So let's hit on a few of these individuals. So we can have influence on eruption with extraction versus non-extraction, habits, airway. Many times by working early, we get a better overall prognosis for the eruption of the permanent dentition. We can maintain space longer, and we may maintain it differently if we know we're going to treat one way versus another. And then the logical way to treat this many times is that we want to try and get done before high school time. It's more of a problem. It's not a problem of growth. Many times it's a semantics problem, because coaches don't want the kids out from sports. Teachers don't want them missing school. And many times the boys are the ones that are developing later. So by intervening early, we might be able to shorten the treatment time in the future and get them done faster. So 2 phases versus 1 phase. If you look at the literature, this is ortho literature. It's talked about a lot by Profit. And what Profit talks about is doing 2 phases of treatment is not as efficient as doing 1 phase of treatment. But when we look at these, we're missing some things if we think about it just that way. So when we talk about the aesthetics, this is what many times the moms are asking. This kid's mom said, hey, I want you to fix the picket fence. And that was her exact terms. So aesthetics mean something very important to moms nowadays. How about the psychosocial? We all know that phones and social media has elevated social awareness to a much younger age. And so bullying is very easy on these social media platforms, especially things like Snapchat. You can snap it and it's gone. And so that's a problem. So taking this into consideration when we're making our early choices for treatment are important. And then things like this, that's me. My front teeth were so big and bucky, I thought myself to be looking like this, but my generation, this is what I really look like. So I was begging for treatment. And then trauma, something also that's not taken in consideration by orthodontists very much, but there's all different types. If you look at that lower photo, that incisor has an incisal edge fracture. This girl had fallen and hit in the jungle gym 2 days before she's supposed to come see me to do some early interventive treatment. And people don't consider contact sports. Some of the sports that they play are contact sports. Basketball is the second most dentally injured sport in the world. Number 1 is actually soccer. So all of these sports actually have a component of trauma that can develop during them. So mouth guards are very important, grinding guards to prevent, in some cases, nighttime wear. And so I'm a member of the Academy of Sports Dentistry, really good information from them. And so some of the early research talks about in the orthodontic literature about overjet, but really the pedodontists have it right. They've done a lot of the studies that led to things like this, that the mesh on trampolines went from open to closed, because during the holiday season, it's one of the #1 reasons for visits to the ER for dental trauma. It was avulsing teeth. This smaller netting was preventing that. And this came out of some of the literature done by the pediatric research studies. And almost all of them proved 2 things. Number 1, overjet, which makes sense, has a big effect. And number 2 is lip competency. So if we can have an effect on both of those, we can decrease the amount of trauma over time. So this is that kid I showed you earlier. We went from this. Oh, for some reason that slide's not loading, but we were able to retract those upper teeth to help with that lip competency. And then the last component that needs more research on both sides, even the ortho and pedo side, is the psychosocial component. What I didn't understand early on in my interventive stages with expansion, with motion appliance, which we'll discuss a little later, and with early brackets, we're seeing fewer and fewer impacted canines. Having an early effect on a canine that is already starting to deviate from its normal pattern can have an overall positive effect. And then the last thing, one of the last things here is airway, which I didn't expect to have an effect the way that it has. But especially with early bite correction and expansion, reading the literature about that in combination with adenoids and tonsils, we're seeing some very good airway effects and sleep effects. So one of the people that has studied this, Morris Poole, he was the president of the AAO, and he had looked at some of the literature, and what he decided is that it's not only a problem with early intervention treatment, it's also an effect from financially. So this was an article published in Yahoo Financial showing the cost of just one traumatized tooth over time. Back to you, Dr. Carter.
Yeah, you did a great job, Mike. I know that whenever anybody brings up the idea of a trampoline, they know that my answer is going to be no. Every
Right.
orthopedist and every pediatric dentist loathes them. And I always say it's easier to fix bones than it is to fix teeth.
Amen.
So some of the appliances that we use in early treatment actually have been used on this set of twins. We had some expansion and we've had some brackets. And everybody knows if you go to any dinner party, oh, I had an expander and we used to turn the key, but it's become much sleeker and easier these days and much more comfortable. But the expansion appliance is one of the most wonderful appliances to help create skeletal harmony between the top and bottom jaw and to be able to fit more teeth in the mouth, or not even more teeth, the regular amount of teeth that didn't fit before. And there are many different designs. The one on the left is the traditional Hyrax or hygienic expander, and the one on the right is a mini screw. And you can see we can get the same amount of force with sleeker appliances that are easier to keep clean and easier to tolerate. Now,
I agree 100%, by the way.
The newest thing on the market is the Invisalign expander, which is worn 24 hours a day, only taken out at night, which means you eat with it, which gives me lots of concerns about cavities. But it's the same thing. A child can take it out. And that is not always helpful because the amount of time that an expander is out of the mouth, not only is it not making the mouth wider, you're losing what you've gained. And we have lots of different appliances. We've had traditional brackets, we've had aligners, and we all know that any force on a tooth will move a tooth. It could be a finger, it could be a retainer, it could be an aligner, it could be a pacifier, it could be brackets, but everything has an effect on teeth. Now, Invisalign first is making a splash, and again, it comes in and it's out, and keeping it clean is always difficult. But this early intervention treatment, which is exactly the term that I use, Mike, is really one where the children want the most bling. And it's also the time where they tend to be not so responsible. How many 8-year-olds remembered everything that they need to do throughout the day? And so keeping it in the mouth is always a challenge. But at this age, bling is better. So they have stickers to go on it. So does it defeat the purpose of having clear aligners? I don't know. But one of the best solutions out there is something called Wild Smile. It's really, to me, the ideal orthodontic treatment for early treatment. So it's the best appliance to treat this phase 1 or early intervention case. It was the proud recipient of the AAO Award for Supplier of the Year. And it comes in 3 different versions. They have the Signature, the College Collection, and the Disney Collection. And this is what they look like when we put them on. The base of the bracket is different shapes, and it makes it super fun. I know with workflow in my office, we start talking about these fun brackets. So by the time the child is ready to pick their brackets, they're all excited about which ones they want. And it really hypes up the whole treatment and takes away a lot of the anxiety of something new that might be coming up. And we know that children have more anxiety now than ever before. So what a fun way to not only improve their smiles, improve your office, and improve your patient's experience.
We do the same thing.
And they pick their different colors, and they have all sorts of fun. And often what takes the longest amount of time is them picking their colors. And if you look at these teeth, they're all looking pretty clean. So this is our signature collection. We have shapes, stars, hearts, flowers, baseballs, soccer balls. We make it any ball you want, footballs and diamonds. And then this is where the rivalry comes about which team is it going to be. Right now, Bama's #1 in the country, but we'll see what's going to happen. Clemson's right up there. You know, you never rule out any of these teams. And then Disney, we have the ears. You can have red ties for Mickey, pink ties for Minnie. You never know what they're going to do. So how do Wild Smile brackets work? They're made in America. It's surgical grade steel, and they're only designed for the upper canine to canine. You can pick which prescription for all the other teeth, but it's really focused for that anterior aspect, and everything is up to quality. But the shape of the base is what's different. And so it helps you position the teeth and also give you that beautiful smile. And here we can see that the width is a little different, and these shapes are what the children are all looking for, which we will turn into a super advantage in a second. We can see all of our patients here. They love what they are wearing, and they love showing their smile. And here we are on social media. We got the big Y, we got some Disney, and our whole team. This is one of my presentations. We had a UF fan right there. And we have this social media package where we can actually have the patient, here it's me, holding the shape that they pick. And it's really fun. And the patients share it. They can't wait to go. I have, oh, my friend next to me has these, but I want to do that. Or, oh, the best friends are going to match with their shapes. And it really makes it so fun. So we found that, and this was a study out of Ohio State, is that 90% of kids in this young age group really prefer Wild Smiles over traditional brackets and aligners. I mean, that's a pretty convincing number. And then we found 70% of kids under 12 the parents are really important in it too. And this just makes it a real slam dunk for how this is so loved. But what really makes it great is not just that it's your smile with a style, but we can turn this into increasing our brushing. Okay, so I always like to say shine your shape. I think Mike likes to say shine till your smile. What's your phrase?
If you can't see the shape,
Yeah. If
you can't see the shape, you're not brushing.
Exactly. And it's exactly what we say. So, you know, when kids, they brush their teeth really quickly, parents want to check, can't see that shape. So I say, shine your shape, shine your smile. We make it kind of fun. And so you can see where oftentimes if we don't brush well, the gingiva from above kind of grows down and gets puffy, and so that shape of the tooth of the bracket can be obliterated. But when you're really shining and brushing, you're getting above those brackets. And brushing above the brackets is actually the place that most patients miss their brushing. They'll brush around, maybe in between, but they miss that upper ledge. And by having that shape, it's a great visual target for children to see if they're brushing effectively. If you think about it, we give them this very loose, go brush your teeth. Well, they're brushing their teeth, but are they brushing thoroughly? Not necessarily. And this is a visual target for them to know if they're doing what they need to do properly. Okay, so we always say, can you see the shape? Go up and do it. And you still need to floss, you still need to follow the rules about no sticky candy, but it makes a big difference. And what we don't want is when braces come off to have these decalcification. And unfortunately, this is one of my cases. I think we all have them, but you can see how the gums are real puffy in that middle slide. And if you're shining your shape, you don't have that. And this is a QR code if you want to know more about Wild Smile. So regardless of what system that you're using, hygiene is essential. When you don't brush well, you do get decalcification. And this is the classic pattern above the brackets. So if you have the shape and you're cleaning it, you won't have this, but it's usually above the brackets and all around. People think the brackets cause the decay. It's not. It's what's left around the brackets that causes the decay. It's that buildup of plaque. And it also happens with aligners. So we know that we need to have good oral hygiene and fluoride and all sorts of different things if we do get to prevent decalcification. But if we do have it, we can treat it, but we just wish we didn't, because nothing is as strong and aesthetic as the natural tooth. So the AAO has a whole campaign about keeping soft drinks away from braces. And aligners, because that's really, diet is really what's going to eat away at your teeth. Acid plus sugar causes problems. And while a lot of days we know that soda is not good, but bubbly water, whether it be the Pellegrino, the La Croix, the bubbly, or even now like Prime, adds increased acidity, which is worse for the teeth. And kids after school, I don't know where you are, but they all go to Dunkin' or Starbucks, and this is what they're drinking. And none of it is black coffee. It's all filled with sugar and syrups and coloring. And this is what's penetrating our kids today. And it's also causing the sugar and our rise of obesity. And this is such a trend that even my dog has a little like puppuccino in the office. Now we know that when we switched from flip tops to screw tops, we used to have exposure, like you would finish the can and then be done. But when we had the screw tops, we'd sip it throughout the day. And we know exposure is like a wave coming across the beach. And with each sip and with each drink, it erodes the teeth. So we're having more erosion with the screw tops as opposed to the flip tops. And now that we have wonderful scanners, we are getting a much tighter fit of our aligners onto the teeth, which means our speech is better and they fit tighter, but the teeth are getting dried out and there's less saliva. So our teeth are more vulnerable to whatever's sitting on them. And if teeth are not clean before the aligners go in, we're going to have problems. And we're actually having a new aligner decalcification pattern. And so we say we need to have clean teeth and a clean aligner together. So don't have lunch or drink your soda or have your meals and then put your aligners right back on, because you're just packing that food into your teeth. And once your aligners are in, it should only be flat water, not just water anymore, because they'll drink their carbonated water, but flat water. But we can use those aligners to our advantage by putting in some preventative paste like a fluoride rinse or a special toothpaste. Okay, and the location of decay is very different with aligners. It's interproximal, it's pit and fissures, it's cusp tips, and it's the buccal and lingual surfaces, as opposed to just around the bracket. And this is a case, not one of mine, but one of my cases where I'm the pediatric dentist, where this is 6 months after wearing aligners without that prevention, and we're getting these interproximal decay. Now remember, it's not just aligners. Our retainers are now those clear suck down Essex retainer or Trutane retainers, which are just like aligners, and it's the same thing. They're often wearing them, not cleaning their teeth, and it's the same thing. And also mouth guards, which we absolutely advocate oftentimes they go from their mouth into their cleat into the bag, and they're definitely not being kept clean. And we all know that these sports drinks are definitely going to make your child a better athlete, but these sports drinks are killing teeth. This was a study, and if you think about it, it was a sports drink 15 minutes a day, 4 times a day for 5 days. That's really a pretty normal amount of exposure. And they found sports drinks had a 1.5% decrease in enamel, and energy drinks had a 3% loss of enamel. I've had patients come into my office and say, oh no, Monster is not an energy drink, it's a sports drink. Well, that's not true. Well, if we look at our acid scale over here, flat water is really the only thing that's safe to drink. Even our carbonated water drops down, and then when we get to Coke, it's 2.5. We know it's like dropping acid on a car, battery acid on a car or on your shoe. It'll completely ruin the finish. But prevention is really the best thing. We can always fix things, but I'd rather prevent a problem than have a problem. And we have to look to evaluate on our patients, what is our risk factor? Oftentimes, the orthodontist thinks the pediatric dentist or the general dentist is managing the prevention, and the general dentist and the pediatric dentist think the orthodontist is providing a prevention plan, and there's like some disconnect. It really needs to be both and unified, but never assume the other office is doing the job. So we know that your low risk is if you have good saliva, good home care, and you're really eating healthy. How many of our patients are really in that? Once we throw in orthodontic appliances, or maybe not the best brushing, or you have that plaque building up, you're way into that moderate. And if you have dry mouth, which could be from wearing aligners and drying out the teeth, or having a terrible diet or drinking those other things, we go to a really high risk. So we have to really watch out and identify what is happening with our patients. We know we talk about plaque removal because that is essential, and we have our regular things like water picks and our, I call them Christmas trees to get in between, but we also need a prevention plan that's a little bit more than that. And that's where we have our fluoride products that come in handy. In office, we can use our fluoride varnish. This is great. It's nothing like those ooey gooey trays from our youth that were filled with slime that you had to keep in for 5 minutes and then you couldn't rinse or spit for half an hour. I mean, parents always tell you the horror stories of that. These are just, you go in and you brush. We have great flavors. We even have an unflavored or no flavor, and the cotton candy, it's just like candy. And it comes in either drops, and you use 1 drop and wipe it on the teeth, or they have ampules where you break the top, use a brush, and brush it on the teeth. For home care, we recommend a 5,000 parts of toothpaste to be used at night. You can use it morning and night, and we recommend spitting and then not rinsing. And then if you're wearing aligners or a retainer, just put that retainer or a liner right in over it so you keep some of that, and it really is almost like a fluoride treatment every night. But it really helps get in all those nooks and crannies that are sometimes hard to get to with all of the hardware. Now we also have sometimes that younger age, they don't know how much to use. You go into the bathroom and like half the tube is all over the place. This is called Just Right, which actually is a metered dose. So you know exactly how much you have. And then the bubblegum flavor is SLS free for any kids with allergies. All of them are gluten free. They have 10% xylitol, and one of these bottles lasts for 6 months, even if you're using it twice a day. So it really is quite a great investment for keeping your child safe, keeping the smile safe, and making everything easy. Now, we talked about having those dry mouths with aligners or with retainers. And so we have a spray or a gel that we can use to help keep those teeth hydrated. Children are on more medications now than ever, whether it be anti-anxiety or allergy meds or lots of other things or mental health things. But oftentimes the side effect are dry mouth. And so we need to protect the teeth from this. Saliva is always our first defense. And this is the highest xylitol percentage on the market for any of these dry mouth treatments. And the pH is 7. And it really makes a big difference. You can also use a spray if they prefer that. And the xylitol really helps decrease the risk of decay and gum disease. So now, as much as we may advocate all of this, sometimes trouble does happen. Sometimes the teeth do break down. So what do we do then? We have something called Advantage Arrest, otherwise known as silver diamine fluoride. It's been around for a very long period of time. But if you start seeing decay, you can dry the tooth, place some SDF on for 60 seconds, and then put some varnish on it, and it can arrest the decay. It will not stain other parts of the teeth or any sound enamel or dentin or tissue, and it's totally fine. And it really works great, especially if you start seeing incipients. It comes in individual bottles with drops or in individual ampules for one use. And it comes in a gel or in the drops. It is 5% fluoride, and it is blue dye, so you don't have to worry about any red dye sensitivities, and it's very safe. And what it will actually do is stain the decay a dark amount. And it's fully approved in the US for dentinal hypersensitivity. A lot of my molar and incisal hypoplasia children, we put this on and it really helps with that. But it also arrests already formed cavities in primary teeth and adult teeth. And it really does prevent tooth decay. In the US, we're just approved for hypersensitivity, but it's used universally off-label. And silver is an antimicrobial, and it also stimulates dental sclerosis and calcification binding of the collagen and the protein. So it really stops. It works beautifully. Now, it will not stain sound, enamel, or dentin. And when it's just sensitivity, it also will not stain. If you do by chance get it on the tissue, on the gum, on the lip, it will come off in a few days, and all you have to do is just slough it off, like with rubbing, normal rubbing. Application, you always have a patient wear safety glasses, you dry the tooth, you isolate it, put SDF on for a minute, wipe off the excess, put on fluoride varnish, and they're good to go. If you're trying to stop cavities, we use it 1 to 4 times annually, usually after one single series. When you go to touch that spot again, it's nice and hard. And for prevention, you use it 1 to 2 times a year. Contraindications, a true silver allergy, and you don't want to put it on the pulp. Now, if they have true stomatitis, you don't want to do that either. But we can take an area that's cavitated, place this on, and we can have that enamel stop progressing and it turns hard. Now, the side effect, it is dark, but then you can easily clean it out and put a white filling on top of it. So it can definitely delay the progress. So who would benefit from it? Basically everybody. Children, older adults, compromised, geriatrics, high-risk patients. Okay, and here is the drop of the SDF with the fluoride. Now, the other thing that we can use is another oral antiseptic, POV1. Now, do not be confused, POV1, with Titleist ProV1. And as a golfer, that's always how I remember the name. So this is basically a disruptor. This combination goes in, breaks up this decay pattern, breaks up this flora, and allows us to stabilize the mouth. So why iodine? It inhibits plaque formation and it kills cariogenic bacteria. Okay, we know that caries is driven by bacteria and we're breaking that up. Okay, chlorhexidine does not stop caries, but our iodine will. And we're hearing about coconut oil pulling and essential oils. There are no studies that prove that. So even our most like holistic moms, we can prove that this is better. Now you can get iodine in the store, right? We've all been using that for years when we either scrub in for OR cases or when you like fall and scrape your knees. I mean, that bottle always came out when I was younger. And you can use it, but it's just a lot messier. We have it all uni-dosed and in a much better form. The other thing that it's really helpful for is subgingival irritation. And what you can do is put this around the gums where you may get puffy. And sometimes our kids do get really puffy gums when they're in orthodontics. And so it will really help heal that gingiva and decrease that irritation. So how do you use it? You rub it on the teeth for 10 seconds and you apply the varnish. So what we do is we have this box and we'll put the first one on and then we send them home with a box and we'll write on it what date to do it. Now, if you have moderate risk, we have them use this every other month. And if it's high risk, we have it use it every month. And here's our box with the dates. Now, something else that's always important and very safe are probiotics, because we know that the gut health and the biofilm are also highly influential in our oral health. So we need a strong prevention plan. We need to talk about diet. We need to talk about the biofilm. We need to talk about saliva. Mechanical removal, get our strong prevention plan with fluoride and antimicrobials, but we need to be coordinated with the pediatric dentist and the general dentist, with the orthodontist, and we have to work together for all of this. So now we're going to go back to Dr. Reagan.
Yeah, and I agree with that last statement too. We just don't have enough synergy when it comes to oral hygiene and the different modalities available that we can send them between each other to make sure things are staying on the right track. So on to current orthodontic trends. Let's start with the 3D workflow. And that starts with scanning. So the 3D workflow is the moment they walk into our office as orthodontists, we're going to try and prep them for the future visits to minimize the number of visits. In this very fast-paced world, with parents coming in and having very little time to see you, taking a scan like this and getting something from it that's not only your photo, and in the case of the Trios, it's even better when you look at the long term. The scan comes out very accurate looking at the gums and the teeth. But then we can take this, and so what people don't realize, so what it is actually, this is what a scan is. People don't really realize this. It's actually not a full scan. It's actually a bunch of small little triangles meshed together, and each of these triangles and the way they're laid out gives the three-dimensional quality to it. So an accurate scan will give you not just what it looks like, but also give you the 3D anatomy that can be used for other things.
No gook, no gag.
Right. So all of us remember that. We used to carry a thing that we'd say, Dr. Reagan's alginate flavors. No one wants that. So we can go to the next slide. So we can also use it for many things. We aren't just using it for the photos, we're using it for our form consent. We can take this model, rotate it, we can look at the heights of the teeth, we can look at the gum tissues, we can look at lots of different components of this to figure out what is our next step. You can see with this, by rotating, we see that overjet. We can see the heights of the molars to know, do we need to put a brace here? Can we put do we need this, does this one need a band on one of the teeth?
I think it's one of the best ways for patient education so that our patients and our parents understand exactly what the issues are and how we can fix it. And it actually increases our case acceptance rate because it doesn't just seem like a black hole.
I agree. And when you used to look at the old 2D images, it's hard to visualize, but that rotation really helps you visualize it. So then we go on to 3D printing. Now, not all orthodontists are doing this, but I started early on with this. It's called the Form Labs printer. And this is the old style printing and takes a long time to do, but it is very accurate. And it is using a laser, and that laser shoots into this molten material and out pops your whatever you're doing. So in our case, the model of the teeth. And that's accurate but slow. So we now use the sprint ray, which is DLP, the same sort of projection technology that's used in cinemas. And we're using it to make some of these things like you saw earlier that Dr. Carter showed, and using it to make appliances. And so from that, you can get different types of appliances. So we're getting your lingual arch can be made before they even get to the office. Habit appliances. This is called a spider expander, which expands more in the anterior than the posterior. And it doesn't stand up well to heat, but some of the new technologies are not allowing it to be done on the model. It's being done with 3D printing of bands as well, which I'll show you in a minute. So this is called the centered appliance. If you look at that band, it looks different. And what's happening here is that this does not go interproximally. So the problem many times is you have to slide the spacer in there, make the space. It's very uncomfortable. And now you've opened up that interproximal area to decay. Well, now you don't have to separate the contact. The contact's still there. They can still floss it. This just actually goes onto the anatomy. It wraps over the occlusal surface slightly, so it actually helps to disarticulate the cases as well. And you can see it here in different types of appliances. The mini click on the upper left, and on the lower right, that is actually what's called a night-eye expander, which will also expand more in the anterior than the posterior. So you can also use it for this. You can have bracket removal with it. If you'll click for the movie, it'll show you that it's not only used to make appliances, but with the technology that's now available, with the brackets on here, it will actually virtually remove the brackets for you. So you go and you select the tooth in the bracket. Is it not playing?
Not playing, sorry.
Yeah, okay. Well, and what will happen is this. It actually virtually removes the bracket and leaves you with a model that you can make retainers from. And the great thing about the retainers that can be made from this, just like Dr. Carter was talking about earlier, is that it actually has a small reservoir built into it that it'll hold a little bit extra of that fluoride or bleaching material if you want to use it in the future. So this is what we've made from the 3D prints we can make our Essex from. The great thing about it can be used over and over. So now you see this one, you can see that little bit of bubble in the middle. That's a great place for fluoride and bleach.
So as comfortable as those sintered bands are, and I have found that my patients are much more comfortable with them because there's not that pressure in between the teeth, we are moving teeth through bones and we are shaping the bones. So they're going to feel something. But there's a new product on the market by Synapse called the Dental Pain Eraser. And it also won an AAO Ortho Innovators Award. And it's one of the greatest new things. So we use it not only for discomfort, but also for pain management. So to manage pain, you can have general anesthesia, conscious sedation, you can give them a shot, but there's also electrical anesthesia, and that's where we fit in. So what is this science? This science is basically, it's a TENS unit. So we're disrupting the nerve, and we're providing this little node in there that's actually going in and making it more comfortable. And we move the appliance back and forth, and it breaks up the pain. So it's basically a TENS unit, and we use it for about 20 to 30 seconds. So you take this and you rub it in the place where you may have some discomfort. It might be if you're giving an injection, it might be where you know you're about to ligate a tooth, or where you just had trauma and a tooth was pushed back. Or one of our favorite uses is a patient who's really sensitive to getting their teeth cleaned. And basically you make the tooth, without feeling numb, not have that same pain receptor. And so we're breaking up that pattern there, and we're making patients happier.
We're also using it on D-bands on those kids that do have that gingival hyperplasia and are really sensitive, so that you can get the cement off and make it perfectly clean.
Yes, yes, yes. Also, if you have an abscess ulcer, you can use it there, or anything like that.
I actually carry one with me. I am very ulcer prone, and if it weren't for it on my trip this summer, I don't know what I'd have done.
Yeah, exactly. Me too. We have a lot in common, but it's really great. And so we actually just sit and rub it right on our.
On areas that have a lot of inflammation or have severe recession, I'm going to stay in that area a little bit longer, about 10 to 30 seconds, depending on the severity of the site, just like this. So the length of time a patient will feel the benefits of the synapse is anywhere between 24 to 48 hours.
So, in a pediatric office, we don't want to have anybody hurt, and they also hate the way things taste. So if I hear, oh, it tastes spicy, I think like sometimes water tastes spicy to them. So if I can do something for pain relief or to help them instead of using topical, it makes a world of difference. So some of my main reasons are exactly for those molar incisal hypoplasia. I'm even using it on my class 1 and some class 2 preps. Definitely for debonds, and absolutely we put on our braces and then we give the patient one to take home, and we actually use that one on them immediately so that they know how to use it and they go home with it. So they have 24 hours of pain relief, and usually the first 72 hours are the worst with getting braces, and they can use it later. If a patient has trauma, hopefully we've taken those teeth out of risk by then, but if they do have trauma, we can use this to help as well. Okay, and also sometimes we have those gnarly over-retained primary teeth that you don't want to necessarily give local to, but they need something to help them out. This is great. I run it around those teeth for about a minute and then it goes. And I use it instead of local these days. So how do you apply it? You need a substrate. So you need either saliva, or what actually makes it even better is Listerine. But if you're working with little kids that don't like flavors, Listerine's not going to work, but saliva does. You need that substrate, and you take those little prongs and you just rub it on the tooth. We show it to the patients on their hands first. It doesn't hurt at all, and they call it like magical. We rub it for about, I tend to use it a little longer, for about a minute, because it's so easy that we can just keep going it, and my dental assistant can do it, or the patient can do it to themselves, and you get a centimeter of depth of pain blockage. And they say 10 to 15 seconds or 5 to 10 seconds for if you're just going to be doing a prophy. But if you're going to do a full mouth, you can do it in 2 minutes, and you can keep doing it. I have a 20-something-year-old patient with a history of cleft lip and palate who is probably self-proclaimed my worst patient. And she said after this, she actually likes going to the dentist again. And if she had this earlier, she would, direct quote, not be the pill of the patient that she is today. And here we are. We actually teach our patients how to use it. Here's our logo right on there. It's a great business card. And we teach our patients.
Rub it around. You can even go on the inside too. Stay open big. And you just rub it around everywhere. There you go. You give it a try, since I won't be home to do it with you. Little circles, keep going. And we do it for 30 seconds at a time. There you go. Keep moving. Come this way.
So one of the things that's great
And you can even put it on your actual tooth as well.
is,
Okay?
is
So
that
back, just try it on your tooth. One more second. Perfect. Just like that.
it's decreased the number of my child's really in discomfort phone calls. And you know, if we have fewer phone calls and we have fewer people coming in for emergencies, it's better workflow and a smoother moving office. So when we were using banded pre-sintered bands, we used it for that. And also if we're trying to move a tooth that's really far back, we can use it that way, and definitely for bonds and debonds. And this is right before when we're using our bands. I'm going to skip ahead and you'll see that parents don't do anything. And this is for the abscess ulcer. It's unbelievable.
Oh.
How much is that hurt on a scale of 0 to 10? Wow, pretty bad, huh?
Yeah.
You say 10?
Yeah.
We'll go around it for about 30 seconds. How's it feeling?
Okay, everyone in this building could do magic. I'm convinced.
What happened?
Everyone in this building could do magic.
Is it magic?
Yeah, you're a magician. You're a magician. You're a magician.
That's Dr. Cosmo, the creator of this. And it's true, it makes it just easier for these kids. So it's making it easier for your office. It's have great patient experience, and it's non-pharmacological. And they can do it themselves, and they can do it at home. Just like that. It also can be used for TMJ, TMD discomfort, and it makes patients happier. Now, some of the benefits, it doesn't affect the microbiome. So many people are worried about taking NSAIDs because it can affect the gut. We have children, parents are very hopped up about, is it safe? My child has autism, the risk of autism, all of these things. We don't have to worry about that. There's no toxicity, there's no gluten. It doesn't interact with the osteoblast, osteoclast cascade, which the NSAIDs do, and it lasts 24 to 48 hours. You know, you don't need a note. In New Jersey, where I practice, for a patient to have Advil, Tylenol, or Motrin administered at school takes a note from me that needs to be, you know, faxed in. It's just a lot of paperwork. So this makes everything much easier. And in fact, we're even advocating it for teething babies. My associate uses it on her daughter every night. She rubs it along those gum pads, and baby sleeps, parents sleep, everybody is happy. And my cousin's son was actually in such distress with teething, he stopped hitting like milestones, as she said it. He didn't want to play, he didn't want to do this. He was a very dramatic child. And once we gave him the dental pain eraser, we used it every night on the gum pads. Baby sleeps, parents sleep, everybody's hitting milestones, everybody's happy. And there are lots of research that can prove all of this too. And I use it for, I don't use topical anymore in my office, and it's made a world of difference, and I actually think it works much better. And we have pain measurement scores based on blood oxygen levels, and it's not real, it's not voodoo, it's legit. There's science behind it. And it really works beautifully in our co-located pediatric dentistry orthodontic care, because patients are afraid of anything hurting them, and we take away that problem. And I'll tell you, as much as we may think that it's good for the pediatric population, I think adult patients feel things way more than the child. So if you have any questions, you can go to dentalpaineraser.com. And I love getting a thumbs up from my patients.
I think the bigger they are, the more they hurt.
Agreed.
All right, CBCT. So this technology has really changed the way that we diagnose. This is the ICAP machine, which is the one that I use. There's many of them out there. I just think this is the lowest dose on the market.
It's actually the one that I have.
And the great thing about it is you take a very low dose screening, initial screen X-ray, and what that does is make sure that they're positioned right before you send the full dose. And so what it does is that you can get a lot of data out of it, not just the bones and the teeth. Of course, the videos aren't going to work tonight, but you can see so much more. So this is actually anatomage. They can actually take the teeth, segment them, and move them. So you can use it as part of not only your diagnosis, but your treatment planning as well. So you're getting the benefit of both.
Yeah, everybody loves seeing these.
Yep. And so then also we use it for a bunch of different other purposes as well. And that is, we have this exam sheet that we go through on each of the different views that we get from the CBCT, and you find different things in each view. So you can go ahead. I don't know why that's a video at this point. Sorry. TMJ. So you can see on the left side of the screen, the left TMJ is nice and round. On the right side is more heart-shaped. So we're seeing things like this in anatomy in patients that don't even have any pain right now. So that explains why many people develop this TMJ problem. As time goes on, they've had the anatomy, it develops when they're in their 20s and 30s. Juvenile rheumatoid, you can see the asymmetry of this, how much more asymmetric the left is than the right. And so when we look at it at the TMJ level, you'll see the right side looks normal and the left side looks micro. So this is that same case with JRA. Idiopathic or progressive condylar resorption. So it used to be called idiopathic condylar resorption, now called progressive condylar resorption. You can see on the right, normal anatomy, and on the left, that TP shape. And what we found that this is not just degeneration. In many cases, it's an autoimmune condition underlying. So it's one of the things that we now send them off to have them evaluated for autoimmune. You look closely, it's kind of hard to see here, but if we click forward, you'll see the next view of it, and that is it's a pituitary stone. This kid was having some trouble growing, and we diagnosed this. They went in and used some ultrasound to break it up, and deep ultrasound, and this kid started having some better growth patterns. Pretty cool. Supernumerary teeth. So in a traditional pano, you wouldn't even see them many times. But if you look at the next view, you'll see that it's actually mid-palatal and actually extending into the nasal cavity. Ectopic eruption, which many times we thought the canine was in different places than it actually is. So the pano view and now the CBCT view shows that it's actually facing forward, not palatal. So this really helps us in diagnosing these cases, knowing exactly where we need to plan our orthodontics, but also helps the surgeon know what to do with the tooth and where to go. Airway, this is T1 to T2 using the motion appliance, which I'm about to show you. And then adenoids, if you look at this, there is no space from the nasal cavity, from the nasopharynx to the oropharynx. That's a huge adenoid. And then we see enormous tonsils as well, almost kissing cousins here. This is a soft tissue, soft palate fused to the nasopharynx, which I'd never seen, but this kid had to go get that released. They were almost breathing zero through their nose. And then of the sinus, if you look at this, your traditional pano view, you may not notice too much, but when you turn it into the CBCT view, you'll see that the sinuses are almost completely full. This is a pneumatized sinus on the left and a pretty full sinus on the right. And this was just after a round of antibiotics on the same patient. Look at the black spaces in the pano, now look at the CBCT view, and you'll really see a much clearer sinus cavity. All it took was a little antibiotic. So this is actually my daughter. She had sinus surgery done. And so you can see at the very top how much blockage there is with turbinates, with the retronasal area. As you go to the bottom, you can see how much airspace is cleared out by doing this. And sometimes this is the best way to get them clearance for breathing and sleeping. These are my daughters. So what I didn't know early on is the younger one had some significant airway issues that I wished I had this technology and I didn't.
I think we say that all the time. I feel like I can't go back to diagnosing with just a
No.
flat pan and stuff now that I
Yeah.
have my CBCT.
100% agree. I don't want to go back.
No. And one of the other benefits is tooth size predictor. You know, before we used to try to predict, are the premolars going to be big? Are they going to be small? And you can't use the x-rays to really tell us that, but you can get a true size, arch length size analysis with the CBCT. So we know whether we're going to have crowding or not. It's not doing those Tanaka Johnsons and the Moyer's analyses and figuring out what crowding we're going to have.
And technology will get better and be able to measure them with AI in the future.
Absolutely.
So missing teeth, there's not a lot of people doing this. We're one of the first ones. We're the first one in the world to do this. And so we've been using TADs to replace these in, the more recent past, but this is what we used to have to go through, right? You have the missing teeth, you put it on the arch wire, and then when they're done with the orthodontics, you have to do this and make a tooth on the wire. Who wants to go through their formative life, dating life, doing this and wearing this and taking it out to eat? So what we've come up with is this.
Oftentimes the canine roots moved and they have to go back into orthodontics before they got ortho. Before
Right.
they got implants. Mm-hmm.
So what we came up with is using true implants, not TADs, but true implants that we call mini implants, usually ones that are designed for the lower anterior for the laterals, and we place them in these spots. And then we have a lab fabricated crown put on. What we're finding after 14 years now of doing this is that we're not only giving them a nice aesthetic, something that can last them through their teenage years, but we're holding bone width and height, and many of these don't have to be replaced. In actual, for the 14 years we've been doing this, we've only had to replace one of these with a new implant, but they're small enough that they can be trephined out over time. And you see here, this is one of these small form implants, small enough that if we had to, we could drill it out in the future with the tooth in place. So like in this case, they had all kinds of missing teeth, and a lot of them have really short roots. So even if we were planning to try and keep them for a while, we couldn't. So in this case, we put them in multiple places. You can see 2 on the lower right, 1 on the lower left. And so we are using these as space maintainers. It's not the perfect crown, but at least they'll hold the space and hold the bone. See them there? And from the side view. So the motion appliance, bite corrector. So many people have heard of the herps and headgear. We used to use those a lot, but this is a smaller, easier appliance to use, and it comes in colors, it comes in shapes, and now there's the new Motion Pro, and the Motion Pro has all kinds of bells and whistles to help you treat these types of patients. And so it's used to connect to the canine and the molar, and by doing so, you upright the molar, you rotate the molar, which many times in class 2s are the case, but you can look as the canine moves back, you also gain arch length in the anterior. So many times I'll use this even if they're just mildly class 2 or mesial drift from early loss of the lateral incisor to regain our arch length. The Motion Pro has this built-in hook and this really nice open pad, makes it easy to hook elastics to and to use the hook to move those anterior teeth. So you see the hook as it goes in can be used in front direction, back direction for different movements. So either you're going to use it for class 2 or class 3, it's used for all of those. So this is that case earlier that it didn't show these photos, but this is the perfect example of where to use that and how the lip competency changed from the top image to the bottom image. We used the motion first, and then we tied on to the motion to the brackets and retracted them to get this type of change. And this is the dental result from that picket fence to more upright. So this is just a few more examples of that. facial, and now teeth. Flared to upright, same thing. Next one, same thing. Just to show you continuous examples of this. And the teeth. All using this motion appliance. Very small and easy. And most parents remember wearing a headgear as a kid and don't want to have to. So this is so much better. How about class 3? So this is the first class 3 case that I ever did. Many of these cases are my first ones. So this is a kid thought would be super easy. If we look at the teeth, you'll see that it's class 3, edge to edge, but I just couldn't get it to cross over. So then I put them in the motion appliance on the bottom. And this is where we got him to after just a couple of months wearing the motion and some braces. So now we're ahead of that growth for the future. And they don't have to wear reverse pull face masks. Dental monitoring. This is one of the things too that, you know, like the CBCT, I don't want to give up on. Dental monitoring is actually using AI and taking a scan with the patient's own phone, and it helps us track progress. So it's this little scan box that you attach your phone to. You place this in the mouth and you take the scan following the instructions on the screen. And so this is a case where it not only helped us, but saved us time. So this is an expander phase 1 case. And so this young lady needed some width, some expansion. For the spacing, you can see no space for lateral incisors, and the centrals hadn't even come in. And what this did is allow us to do the treatment without having to bring them in so often. So we can track the movement. You can see the band on that upper photo. We're tracking the width. So the expander here, if you look at this, it's not expanded. And now in the next picture, you'll see that it's expanded. So it actually helps us to prevent problems where a patient's not actually turning it. We'll know very early, within the first week or so, whether it's being turned or not. And if not, we can give them instructions, either remotely via video or bring them into the office. So we can track it from T1 to whenever the next time is. And we don't have to bring them in to check it. So the first visit's cement it, the next visit's put the braces on. Saving time for the parents, especially ones that are worried about time. So in that case, you see there was a little bit of the bar in the tissue. So we've got these notifications that we can send them. Hey, time to come in and take a look at it before it becomes an abscess. Or if we see it's not moving, we've got some things we can send to them. And these are all canned so that we don't have to retype it every time. We can just send it to them that way. So once it's fully turned, we can see it looking good. Nice job. So it's a positive reinforcement tool as well. And now we're waiting for eruption. So we don't have to keep bringing them in over and over again. We can also monitor their hygiene. You can see this is the Wild Smiles hearts. And you can see that she's doing a good job on the top because you can see the shapes. So we just keep monitoring progress until it's time to bond to those teeth. So here's another example where you can use the Wild Smiles, not just the same bracket, but you can alternate them. So we got Mickeys and stars and Mickeys and stars. But you can start to see a little bit of change in some of these photos where you can't see the whole Mickey ears. So we know in these cases, we need to brush. Well, what this does, a combination of Wild Smiles and DM, we can head this off before it becomes one of those cavities or decalcifications. So now we know we can send them some information and say, hey, we can't see your footballs. You need to get that toothbrush above. And we have some canned videos that we send them to help with that. This is the case with the motion appliance in DM. So with motion appliance, it helps us track the progress as well. So this young man has a class 2. So we're going to put him in the motion appliance and follow it with DM. And you can see on the lower right, it says R and L. That's the molar and the canine. So you can track the progress. AI is tracking it for you as well as the visual cues. So you can see on that upper left, now we're starting to overcorrect. And we've got these also canned responses. Okay, you're in this band, switch to this band. So we don't have to bring him in for all these different visits. And for the mom who plays tennis or for the kid who's in sports after school, they don't have to miss so many times to come see us. And we're keeping we're staying better on track. And what we call it is weekly house calls. So we can track the progress to make sure that it's progressing and not staying where it shouldn't. So you can also use it for positive reinforcement for this. Hey, everything's looking great. What size bands you're on. We can keep progress, keep track of things without them coming in the office. So now you can see that we've changed one side class 2, one side's class 1. We know it's progressing right. See on this side, it is still class 2. So we keep them moving until we start to get class 1 or super class 1. And that's why you see the left side showing class 3. So we're correcting and overcorrecting, and now we're going to use it for the same thing. Wait for eruption. As we see with this case, the kid has the home plate or Superman symbol. Wild smiles. So that's all I got for you. Dr. Carter, anything else from you?
Oh, nothing. I love Girls on the Run. I'm a huge sponsor. So you have Wild Smile QR code here and both of our emails. I want to say thank you. Hopefully you have learned all the ways to identify early problems, some ways to treat them with awesome Wild Smiles, and how to keep them clean, giving your patient the target to shine that shape, and all the preventative measures from Elevate to keep our teeth clean and healthy, and how to fight cavities as well. And when they're going through this orthodontic process, we can help them with discomfort, and we can help monitoring from home to increase your workflow and office efficiency and be respectful of our patients' time. So thank you.
Thank you.